Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Japan, Prof. Atsushi Kanoki. Prof. Kanoki is the director of the Department of Neurosurgery at the Konan Hospital, Taihaku, Japan. He is a board certified neurosurgeon in both open and endovascular neurosurgery. He did his postdoctoral fellowship at the UCSF USA, and he has special interest in treating brain aneurysms, vascular malformations of brain, carotid occlusive diseases, and Moyamoya. We are extremely honored to have him today at our webinars, and today he will be talking about bypass techniques in Moyamoya, historical evolutions and concepts. The speaker for the second session of today is our honorable guest from China, Prof. Jian Wang. Dr. Jian Wang obtained his MD degree in neurosurgery from the Nanjing Medical University and then became a neurosurgeon at the third affiliated hospital of Nanjing Medical University. He did his postdoctoral research on the neurobiology lab at Nanjing Medical University, and his research focused on the developing new techniques for medical imaging, processing and analysis and application of neurovascular imaging on hemorrhagic Moyamoya diseases. He has published over 10 papers in SCI journals, including AJNR and Neuroradiology, and is a principal investigator of several grants in Changchou and Jiangsu provinces. We are extremely honored to have him today at our webinars, and today we will be talking about extracranial carotid stenosis in Moyamoya. The chair for the first session of today's webinar is our honored guest from Novosibirsk, Russia, Prof. Andrei Dubovoy. Prof. Dubovoy is a consultant neurosurgeon at the Federal Center of Neurosurgery in Novosibirsk, and he specializes in the treatment of cerebrovascular diseases, especially complex aneurysms, AVMs, brainstem canals, and carotid vascular diseases. He was trained by world-renowned neurosurgeons like Prof. Juha Harnes-Niemi and Prof. Martin Batak, and he has published extensively in several peer-reviewed journals, and we are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from the UAE, Prof. Wasim Aziz. Prof. Wasim is the head of Department of Neurosurgery at the Sheikh Shakput Medical City, Abu Dhabi. He is a hybrid trained neurosurgeon and specializes in both open and endovascular neurosurgery. He is a vastly experienced neurosurgeon with over 23 years in dealing with complex cerebral and spinal pathologies. He is a distinguished professional in both academic and clinical settings. He previously served as a consultant and head of Department of Neurosurgery at the Med Clinic and a consultant neurosurgeon at the Tawam Hospitals. He received his fellowship in skull base and endovascular neurosurgery and neuroanatomical studies at the Keio University in Japan. He then completed research fellowship at the Barron Neurological Institute in USA after receiving training at the Foundation A. Rothschild in France. He was granted the prestigious Associate Professor title in 2018 Department of Neurosurgery at the University of Alexandria. We are extremely honored and grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Prof. Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Sen from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Prof. Andrei Dubovoy.
Thank you so much, Raja. Today we will talk about very interesting topic, Moyamoya disease. This disease has widely spread in Asian population, but sometimes it happens in Caucasians, and any neurosurgeon have in his practice patient with Moyamoya. But sometimes many questions about treatment, about pathogenesis of this disease is not very clear. And today we will discuss about this. And I'm happy to introduce our first speaker, Professor Atsushi Kanoki, the role of bypass techniques in Moyamoya, a historical overview and evolution. Please, Professor.
Thank
Are you
you
ready?
for
Yes, thank you.
Chairperson, and I'm honored to be here today. So I'd like to start my presentation. There's no COI, So today's agenda. At first, I give some introduction, and then talk about history of Moyamoya disease, and show my representative cases, and conclusion with the next step of Moyamoya disease research. So. The number of surgery, open surgery in the world is decreasing. The Dr. Michael Lawton is one of the famous neurosurgery in the world. Showed the slightly decreasing the clipping of aneurysms, but the increase of bypass surgery. So, in my experience, excuse me. So, recent 2 years, I clipped more than 100 aneurysms and do around 80 to around 80 bypass surgery, and also doing some endovascular treatment. So I wanted to speak about the complex bypass surgery and the difficult surgery, but I really think the basic procedure is very important. So I'll talk about bypass surgery of SDMCA, especially Moyamoya disease. So I also do some complex cerebrovascular diseases like complex aneurysms. Here's the unruptured giant MCA aneurysm. You can see the M1 going to giant aneurysms, and three different branches coming out from aneurysms. So I I made a fusion images to prepare how do I how I doing bypass surgery for this patient. This patient has need two bypass for the EC to MCA. I mean SDA to MCA bypass, and high flow and another other high flow bypass to the M2 proximal. So here's the postoperative view. You can see the giant aneurysms are ruptured. I punked and collect the tissue from aneurysms, and we can prepare for the bypass surgery before operation using some kind of images. So you can see, I could see here and here for M4, and I did double SDMCA, and then I do high flow bypass using saphenous vein graft. But I, as I told before, the SDMCA is basic and very important procedure. So this slide shows the Michael Rotten also say the same things. ECIC bypass is most cases, in most cases, he did ECIC bypass like SDMCA, and the target disease is Andrews and Moyamoya disease. So, in this stage, there are many Moyamoya disease patients. So, I usually do operation for Moyamoya disease patient recently. There's a history of bypass surgery. In 1967, Yasujer reported the first SDMC bypass, and then Barnett, Koss, Kmos, and says there's SDMCA bypass for ischemic conditions. It is not useful procedure in COS and CMOS. Here's the COS study, but there are some problems in this study. So one is the complication just after surgery, and so the time for the anastomosis is was more than 40 to 60 minutes. So the bypass surgery is less qualified. Here's the Japan adult Moyamoya trials. This study shows the efficiency of SDMCA bypass for Moyamoya patient, which suffered from hemorrhagic onset. Here is the surgery prevent second attack. So here's a CMOS study. Sorry for my slide is enough for the English presentation. That's true. So this study has some problem. Patients select the time for surgery and follow-up duration. So they trial for the CMOS2 study to, up to 2027. By the way, the history of Moyamoya disease, the first report of angiographic uh, features of Moyamoya disease was in 1957. Uh, and then Kudo and Suzuki reported the more precise and fine um, document for the Moyamoya disease. But the Suzuki, his name is Jiro Suzuki. He's a professor of Tokyo University Sendai at the first, and he said Moyamoya vessels are collaterals of the brain in 1963. So nowadays we say this disease, Moyamoya disease. In terms of diagnosis, 2022, the Japanese Ministry of Health, Labor and Welfare Japan reported the recent diagnostic criteria for Moyamoya disease. It says radiographical findings is stenosis or occlusions in arteries centered to the terminal portion of the intra-arterial carotid artery. So nowadays we can diagnose even if the Moyamoya vessels appears only in its hemisphere. And also, we can diagnose with only MRI and MRA. And so we need to watch the differential diagnosis. Like autoimmune diseases, meningitis, and so on. So they say the thyroid disease is common for the Moyamoya disease. So I mean, the thyroid disease occurred in Moyamoya diseases. So autoimmune diseases. The thyroid autoimmune diseases is exclude from occurring Moyamoya disease. In terms of surgery, here this slide shows the indirect bypass for the Moyamoya disease. So at first, 1977, Carosol reported EMS, and many neurosurgeon refined and add some tips. So nowadays we use meal like superficial temporal muscles and peritoneum around the frontal bone. But I'm doing combined surgery, meaning indirect and direct bypass, like STMCA and STACA, so on. Because why do I select combined bypass? First, superiority of combined bypass in adult Moyamoya disease. And second, favorable long-term outcomes. Third, combined bypass surgery at MCA territory also save ACA territory with indirect bypass. And last, synergistic interactions between direct and indirect bypasses in combined procedures. I would use combined bypass procedures for Moyamoya disease, especially in adult. For a child, indirect bypass is also enough efficient. So here's my procedure. So I show some video for typical procedures. Expose SDA for around 8 centimeters, then harvest SDA, then flip the skin, muscles, and made craniotomy and open the door, then doing IC green video angiography to select the recipient. In this case, I chose the M4 for going to frontal lobe, and then made fish mouth portion and do color the external membrane and then measure the SDA and M4 and then clip temporarily M4, then suture the vessel wall to harvest the tissue and then made a state suture like this. And then carefully stitching intermittent and then check the other side where if the other side of wall and then made knot carefully. Finally release the temporary grip and made sure how many needles are used and then release the SDA proximal flow. So after I also doing a CD videography after anastomosis for checking the bypass patency, and then doing the indirect bypass So here is the suturing dural muscles, and then dural insertion for larger area to indirect bypass, and then close the wound. So there are some tips for bypass procedures. The most important things is imaging of imaging the final view. I mean, after bypass, the SDA going like this, and so need to. So I uh, release the SDA flow before select the position of uh, SDH, and also watch the untwisting the recipient vessels and sufficient graft length, and adjusting the position of needle and suture before starting suturing. In terms of angle vessels, I prefer vertical side, but need to do like this. So the younger neurosurgeon need to practice both way to bypass surgery, and this procedure also use for the high flow bypass or deeper bypass procedures like OIPCA and STPCA. So from here, I show some the result of the surgery of Moyamoya disease. This shows the indirect bypass is enough for I mean indirect bypass is modern consultative therapy, and so of course we need to select the patient. We would say indirect bypass is more efficient than consultative therapy in the future. This slide showed before the jump trial is showed the reduction of rebleeding after bypass surgery for hemorrhagic onset patient. Especially for posterior hemorrhage type, like corridor anastomosis is associated with posterior hemorrhage. The corridor anastomosis were reported in 2003. So the corridal artery going to the brain and the surface of the brain like M4 and M3. So here's the associate report after JAM trial. It shows posterior hemorrhage is associated with an extremely high rebleeding rate, and the presence of choroidal type collateral circulation significantly increases the rebleeding rate, and PCA involvement is also independent risk factor. Even in non-hemorrhagic hemisphere, if the choroidal artery is dilated and developed, the initial hemorrhage rate is higher. It is 5.8 per year. In cases with cerebral circulatory insufficiency, the rebleeding rate is higher than in case without it. Choroidal type collateral circulation is more frequently observed in hemorrhagic type cases compared to ischemic types. In all these situations, bypass surgery has also been shown to reduce the risk of rebleeding. Here, this is one of them. So, periventricular anastomosis in Moyamoya disease. So, from the left to the right, lenticular straight anastomosis, thermic anastomosis, corridor anastomosis. Corridor and thermic is more danger anastomosis, but we need to know the lenticular straight is also dangerous. So in this study, in terms of subarachnoid hemorrhage, here the distribution of subarachnoid hemorrhage in basal system the most cases consist in anterior type. So we need to know subarachnoid hemorrhage with Moyamoya disease is would be prevented by bypass surgery, but there is still unknown cases. So here is the location of ICAH. I mean, where is the anterior and where is posterior? So we need to know which parts are parted in posterior type. So this also one of the JAM trial sub-analysis. So choroidal and also thermic collaterals are more dangerous anastomosis in Moyamoya disease after hemorrhagic onset. So in terms of education, I teach this scheme to the younger resident. So here is the lateral view of ICAZ. The corridor going like this. You can recognize the patient has corridor anastomosis. So this scheme is very good for the younger neurosurgeon. The other groups in China also says the corridor anastomosis is dangerous for rebreathing in Moyamoya disease. And this report interesting for direct bypass for Moyamoya disease. They say when we do bypass procedures posteriorly to the central sulcus, the corridor anastomosis will disappear more. So I I'm doing the STMC bypass. Posteriorly, I mean parietal lobe M4 for the patient who have corridor anastomosis, even if they are ischemic cases. So we need the next stage for the Moyamoya diseases. I mean, we need to know much more, much deeper knowledge, like whether asymptomatic cases and elderly cases. So in Japan, we are doing many studies for these questions. And so here the asymptomatic cases. So asymptomatic case, the Moyamoya patient more will have more hemorrhage, even in asymptomatic when they are diagnosed. So the collateral anastomosis is still dangerous. So grade 2 corridor anastomosis is risk factor for the hemorrhagic stroke in Moyamoya disease patient, asymptomatic Moyamoya. Here is the second reports about asymptomatic cases. So disease progression prior to transient ischemic attack is a significant predictor for TIA, and microbreeds also the predictor of disease progressions. So we need to watch carefully the patient, even if they're asymptomatic. Oh, so I have forgot the made a conclusion slide. So I showed some procedure. I showed my procedure, and I showed history of Moyamoya disease and surgical procedures, and next step of our questions. So thank you for.
Thank you, Professor Kanoki, for your very interesting lecture, for your experience of treatment this very difficult disease. And I have one question about your experience. Sometimes I have Moyamoya patient with ischemic stroke in posterior cerebral artery territory. Do you prefer to use as a donor for direct bypass in these cases occipital artery, or you always use a superficial temporal artery for direct revascularization of the posterior territory ischemic stroke of this patient? Tell me please
Thank you
about
for
your
questions.
experience.
Yeah. So I'm doing. I in it depends on the cases, but I usually use occipital artery for PCA territory
And
because you
you,
can. Yeah. So
okay, thank you for your answer. And you use two approaches. One of them to perform direct bypass, and other to perform indirect bypass with temporal muscle, or not, or you use only one surgical approach, and as indirect bypass you use only periosteum in these cases.
I use both tissues like muscles and periosteum. So I made a larger craniotomy
Okay,
for indirect bypass.
thank you so much for your answer. Does anyone have any questions from audience?
We can invite our second chair, Prof. Wasim Aziz also.
Thank you, Professor. This nice talk. My first question is how large your craniotomy is? Do you prefer larger craniotomy, smaller craniotomy for direct bypass? And what risks between larger craniotomy and smaller craniotomy?
Thank you for questions. In my cases, I made a larger craniotomy for a combined bypass surgery, and I can choose the most suitable vessels. So you can see many vessels in the field. I mean, yeah. So basically, I made a larger craniotomy for direct bypass.
Did this carry a little bit higher risks if you choose to have a smaller craniotomy? Do you think it can differ in risks of surgery, having a large craniotomy than a smaller craniotomy?
What risk?
Because larger craniotomy has lots of risks of like bleeding and issues with the middle meningeal artery, for example.
Oh, I see. So, I don't think it's a risk.
It doesn't increase the risks.
No.
Any questions from my co-host Libun Sen?
Yeah, thanks, Raja. Thanks, Prof, for a nice lecture. I have three questions, Professor. In Japan, you have a brain scan program where now you're detecting more asymptomatic patient with Moyamoya, and you show that the papers show that they do bleed despite asymptomatic. Do you think that the definition of asymptomatic is still need to be improved because the main aim is to reduce the risk of bleeding, and you show that they are also at risk of bleeding within 5 years. My second question, Professor, and the successful of the bypass are usually indicating by the MCA perfusion study. Do you think that the emphasis should now look at also the resolution of the Moyamoya vessel to show that a reduction of the risk of symptom or event reduction? And my last question, Professor, this is something same with Dr. Prof. Wasim question regarding a larger and smaller craniotomy. In a patient that you plan for surgery who already developed some collateral from ECA, would that predetermine the size of craniotomy or direct or indirect bypass that you want to perform? Thank you, Professor.
Thank you for the questions. So the first questions, I think it will change the criteria, the indication for the asymptomatic moyamoya. But now the study is ongoing, so we need to wait for a bit time. So I think it will change for prevent asymptomatic patient to prevent a hemorrhagic event by doing bypass surgery. And the second one is sorry.
Regarding the success of the bypass, usually we do a MCA perfusion study. But do you think that that is enough, or should we also study the resolution of the Moyamoya vessel? Would that be an important part of the study to look at the success of the surgery?
Yeah. I think I think it's enough for to see the result of surgery, like SPECT or CVF study is good for the Moyamoya disease, because after bypass surgery, the CBF increase in MCA territory and also ACA territories. So and also the symptoms like TIA reduced after surgery. So it's enough, I think.
And size of craniotomy for those with collateral. Yeah.
So basically, I checked the angiography before surgery, and if patient have no EC to IC anastomosis, I made larger craniotomy. And if patient have some transdural anastomosis like MMA to MCA and STA to MCA, I carefully reject these arteries and make as large as possible, or as large craniotomy as possible I can.
Thank you, Professor.
Thank you. Yes, Ben?
Yes, hello, Professor. Thank you for your lectures, and it's indeed a very wonderful summary of the Moyamoya disease. I would like to ask about in your surgery. So sometimes the Moyamoya patients have the anterior cerebral artery territory, the ACA territory ischemia. But sometimes the STA may not have enough length to anastomose to the ACH2. So what do you think about this and any solution to this?
Yeah, thank you for your questions. It's a very good point. And so I made a larger craniotomy to the near the midline. So above the linea temporalis. So basically, we make SDMCA. So the CBF of MCA territory increased, and then also ACA territories CBF of in ACA territory will be increased, but for insurance, I made indirect bypass around ACA territory.
Right, thank you. So I think there are no further questions. We can take the concluding remarks from Prof. Dubois.
I have a question.
Okay. Please go ahead.
Okay, Professor, I have a question I want to ask you about the asymptomatic Moyamoya disease. If a patient, he was a symptomatic patient, we can see that the patient has some prevalence for the future, have the hemorrhagic events occurrence. Yes. So I have a case. This is a symptomatic male patient about 50 years old. One hemisphere, the patient has the peripheral aneurysm located at the anterior choroidal arteries, and anastomosis to the medullary arteries to the posterior portions of the parietal arteries categories. After the after that, sorry.
There is some issue with the mic, I think. Yes. Can you please repeat your question, Prof? Can unmute your mic again.
Hello.
Yes, please go ahead.
Oh, okay. If this peripheral aneurysm located at the anterior carotid arteries and anastomosis to the posterior portions of the parietal territories, the initial state, the first, I got the SGMC bypass and the edamers. The patient got the grade A masseterial anastomosis result, but I see that the patient is peripheral aneurysms was not occluded, dispelled. So about this patient, as a symptomatic patient, what is the further I can do for that?
Can you unmute your mic, Prof? Prof. Kanoke, please unmute your mic.
Yes, this is my question. Thank you.
Sorry. So thank you for the questions. So you have difficult cases. So you mean you did STMCA to one hemisphere, then but there's collateral in the same hemisphere, right?
Yes, the same hemisphere.
So so how do the so-called target bypass for this patient? So you can see which branches is supplied by carotid artery and using DSA or MRI, and then you made a bypass for that MCA to reduce the collateral flow from the periventricular anastomosis.
I know that, but the first time I have got the revascularizations, after about 6 months later, I got the follow-up. The aneurysm was not dispelled. So how about the further I can do?
So
And
what about the endovascular surgery?
Maybe, but because this patient is a symptomatic patient, he refused to go to the endovascular glute. Yes. So, but according to the MOIs, yes.
Very difficult patient.
Okay, thank you.
Thank you very much, Prof. Dubois. We can hear your concluding remarks.
Thanks for all, dear professor, dear guests. Thanks for questions and for answers. If we had enough time, we could discuss this topic for a long time, but we should to discuss our other topic, and of course we close this first topic and move to next one. Thank you.
Thank you very much.
Thank you very much, Prof. Kanoki and Prof. Dubois, for this very exciting session. So now I'll move on to the second session, and I'll hand over this podium to our Honorable Chair, Prof. Wasim Aziz, who will say a short introduction and invite Prof. Jiang Wang for his lecture. Prof. Wasim.
So thank you, Roger. Thank you. Thank you again for the extracranial stenosis in Moyamoya. It's a very important topic and new to me. So I need to understand more from Professor Wang. Thanks, Professor Wang, for this great topic. Thank you.
Okay. Thank you very much. Thank you very much. Have this chance to have a discussion and the meeting with all the professors. Thank you, Professor Yuko and Professor Shu Bing. Invite me have a chance to about this topic. My topic is about the extracranial carotid artery stenosis in Moyamoya disease. I'm Wang Jian from the Department of the Neurosurgery in the third affiliated hospital of Nanjing Medical University. I was focused on the Moyamoya disease, especially the hemorrhagic Moyamoya disease. Okay, we can see that the disease progression may be the leading cause of the Moyamoya patients who got the futures advanced cerebrovascular disease. This is a paper demonstrated about the 2005. We can see that about 23.5% of the patient got the disease progression during the period of about 6 years. All these disease progression may occur in the major intracranial arteries, both in anterior and posterior circulation, both symptomatic and asymptomatic patients, and both bilateral and unilateral types. Also, about over 50% of these patients with disease progression will develop ischemic or hemorrhagic events. With the major intracranial arteries disease progression, in response to this progression, maybe the terminal portion and the proximal portion of the ACA and MCA will got a progressive shrinkage of the involved arteries. This is representative cases about this phenomenon. We can see that this is the initial baseline state of the patient. This is the just disease progressions MRI. This is the 4 months later. 4 months later about disease progression. We can see the left hemisphere, the stage is about initial stage is about stage 2, and after the intracranial disease progression, the patient, we can see that proximal portion of the MCA is occluded, and the stage progressed into the stage 4. Also, we can see the right images of the MRI. We can see the terminal ICA, proximal MCA, and the proximal ACA got diameter reduction. Yes. After about 4 months later, we can see the diameter of these arteries prior to disease progression was further progression. This is another research about extracranial carotid arteries. We can see that this is a polyline graph demonstrates the serial changes in the carotid canal diameter in the hemisphere with spontaneous disease progression during conservative follow-up, and those without disease progression. We can see at the first time with just disease progression, the carotid canals may reduction in the diameter. After about 50 years later, maybe the diameter will further progression, maybe a reduction to the 85% of the initial level. So we can see maybe the extracranial carotid arteries may respond to intracranial disease progressions got the progression range like the stenosis progression. So this is another cross-sectional study of this patient. We can see 3 types of the extracranial carotid arteries. The first one, we can see the diameter ratio ICA versus CCA is about 0.81. It's similar to the normal patient, normal healthy controls. And the next 2 patients is extracranial carotid arteries. We can see the ICA-CCA ratio decreased below the 1.5%, named the champagne bottle neck sign. This is a very interesting phenomenon in Moyamoya disease, and there is less we can see in the other cerebral vascular disease and other disease. In the hemisphere presented with the champagne bottleneck sign, the ipsilateral, the hemisphere will got a more surgical stage, advanced stage, and the more worse cerebral perfusion, and more prevalence of the symptomatic further adverse cerebral vascular disease events. In this patient, the most enrolled patient is about ischemic patients. The relationship whether exists in the hemorrhagic Moyamoya disease is not demonstrated. So about 2 years later, our team got a further cross-sectional analysis about these champagne bottle lines and whether have the relationship with the hemorrhagic Moyamoya. So we can see that after the Martin-Wright analysis, we can see the carotid champagne bottleneck sign. We can see the maybe means extracranial carotid artery stenosis is associated with the clinic with the intracranial hemorrhage. So in this topic, we want to measure the changes in duct diameter ratio during the follow-up period in the conservative treatment, like the natural history, and assess the association between these characteristic extracranial carotid artery stenosis progression and ipsilateral new adverse cerebral vascular events according to the natural history of Moyamoya disease. So the recent 6 years, we enrolled several myeloma patients, and also we enrolled 10 healthy controls matched for age and sex. The myeloma patients had over 6 months of clinical and imaging follow-up, and at least one non-operated hemisphere were considered to assess. But if the patient is distal CCA to the proximal ICA exceeded several factors influencing the diameter ratio measurement, and some factors influencing the cerebral adverse cerebrovascular events occurrence may be occluded, such as unstable angina or myocardial infarction with the previous 6 months, and a malignant tumor and bleeding diathesis and uncontrolled diabetes mellitus and the uncontrolled hypertension. Also, the patient at the initial state had an unstable TIA at a frequency of over 3 times per month were also excluded. Also, the patient presented ruptured intracranial aneurysms that have not been treated were also excluded. So the patients in this cohort with myeloma disease and period healthy controls underwent 12 MRI with large longitudinal coverage at baseline and follow-up appointments. So the patient got the routine treatment. If the ischemia or the ischemia, we got the CT perfusion and got the cerebral vascular revitalizations in the hemisphere, or if the patient got the intracranial hemorrhage, we got the SWI imaging to determine the hemorrhage site of the location, and got the targeted revascularizations to these territories, and improved further intracranial hemorrhage. Also, if the patient have the aneurysm, they got the aneurysm clipping or endovascular treatment. Also, the patient, if they refused to got the surgical intervention, we have got the conservative treatment. So the brain MRI with 12 MRI were then performed every 6 to 12 months during the follow-up to evaluate the occurrence of the new ACNS. If in the follow-up period, if the disease progression was suspected on 12 MRI, or if new ACNS occurred, maybe the cerebrovascular disease was performed within 1 week. Also, we can got the further intervention. This is a measurement of these characters. This is a DSA's measurement. We can see the we want to measurement the diameter ratio for the ICA versus to the CCA. The terminal portion, the terminal point about the proximal ICA, we choose below the mandibular bone, 1.5 to 2 centimeter above the carotid bifurcation, and the proximal point, it may be the distal CCA, we choose the proximal aspect to bubble 1 to 1.5 centimeter below the carotid bifurcation. Also, these characters was measured on large longitudinal coverage 12 MRI or common carotid angiography. This is the baseline characters of the study patients. We can see about 45 patients got this evaluation. In this cohort, we can see the patient had more prevalence of the dyslipidemia. Also, about 2/3 of the patients got the intracranial hemorrhage in the initial state. This is a baseline vascular characteristic in hemisphere with and without new ACNS during follow-up. We can see in hemisphere with new ACNS and without new ACNS, we can see the stage, Suzuki stage was similar. Yes, right? The Suzuki stage over stage 3 may be named the advanced stage. We can see maybe the hemisphere with new AC occurrence had more prevalence. The involved PCA was similar between these two groups. Also, we can see the collector, maybe the preventricular collector anesmosis scores like lenticulated arteries, carotid arteries, and the thalamic arteries is with the medullary artery and anesmosis score. We can see that there was no obvious difference between these two groups. Also, in the hemisphere with new ACNS group, you can see the more prevalence of the collateral vasoarism. We can see that the key point in this topic, the diameter ratio of the ICA versus CCA, we can see the new ACA's occurrence hemisphere had more smaller diameter ratio, but the differences were not obvious. In this 45 patient is 16 non-operative hemisphere. Yes. In the baselines, the diameter ratio of the ICA versus CCA, the values was 0.54 nearly in patient Moyamoya disease and 0.78 in health controls. We can see there was obvious difference between these two groups. After about 2 years later follow-up, we can see the mean diameter ratios was similar with the initial Moyamoya patients and the health controls. In these 16 non-operated hemispheres, about 5th patient were observed the occurrence of new ipsilateral ACES, included 7 cases of ischemic stroke. Most of the cases was washer infarction, and 6 cases of intracranial hemorrhage were observed, including intraventricular hemorrhage in 4 patients, intracerebral hemorrhage in 1 patient, and a spontaneous subarachnoid hemorrhage in 1 patient. The interclass correlation coefficients of the diameter ratio and the inter-rater reproducibility was moderate. We can see this is the changes in the diameter ratio in hemisphere with and without new occurrence of the ipsilateral ACS during the follow-up. We can see that in the hemisphere with no new AC occurrence, the diameter ratio was most located in the minor 0.1 to the 0.1 large scales, and the patient had a new AC occurrence. We can see that the diameter ratios reduction got a further large scales, maybe further to maybe have the large scales reduction. Yes. Of the 20 carotid arteries in health controls, 80 had a reduction and ranged from the 0.01 to 0.06, and 12 had an increase in diameter ratios. But compared health controls and Moyamoya disease, we can see the whether the reduction or the increasing in Moyamoya patients group is more have the larger scales. After the ROC curve analysis, we can see that the best diameter ratio cutoff point for differentiating your AC occurrence from non-occurrence was the reduction or increasing of the diameter ratio 0.075. Yes, we mean the reduction 0.075 and increased 0.075. This is a detail of the clinical features of patients with new occurrence of ipsilateral ACE still following up. We can see that about 13 patients got new ACS occurrence. We can see that the most ACS occurrence were related to disease progression. Also, we can see the major intracranial arteries progression, but also we can several or maybe about half of the cases were related to the extracranial carotid arteries. We can see previous data denied the reduction or increasing of the diameter ratio 0.075. We can see this is case 1, case 2, case 6, case 8, case 11, and case 12 was all related to this phenomenon. This is another table with association of ipsilateral new ACE occurrence with the clinical and vascular characteristics. After all the adjustment risk factors, we can see that extracranial carotid artery stenosis progression was still associated with the occurrence with the ipsilateral ACE occurrence. But we can see that the MIASP measure intracranial arteries stenosis progression was not observed this association. But interestingly, there is a result in this cohort maybe have the bias of our choice. The use of antiplatelet agent have a association with this phenomenon. These representative cases. The case 1. This is a 63-year-old with Moyamoya disease experienced spontaneous subarachnoid hemorrhage. The picture A, C, and E was the baseline initial state of state angiography and CT imaging. The patient has got the conservative treatment. After about 39 months later, the patient revealed a recurrence of the spontaneous subarachnoid hemorrhage in the ipsilateral hemisphere during the follow-up. We can see that the intracranial surgical stage was similar between these two groups, but we can see that in the posterior circulation, we can the later posterior cerebral arteries have located peripheral aneurysms. Yes, we can see got the large dilated. Yes, right. After the measurement of the diameter ratio of the ICA versus CCA, we can see the initial state. This diameter ratio is about 0.50, but at the follow-up period, about 3 years later, the diameter ratios reduct to the 0.32. We can see maybe reflect to the ICA's diameters decreased. This is another case. This is also another case with Moyamoya disease expressed spontaneous subarachnoid hemorrhage. Yes. After the patient also got the conservative treatment, after about 57 months later, the patient revealed a recurrent hemorrhage around the initial hemorrhage site. We can see that in the posterior circulation, we can see the microaneurysms located in the later posterior carotid arteries. Yes, in the initial baseline, but after about 5 years later, we can see the aneurysms are dilated. But after the carefully measurement for the diameter ratio of the ICAs versus CCA, we can see that the diameter ratio increased from the 0.39 to 0.60. Yes, we can see. Also, we can find that the lumen diameter reduction in the CCA. We can see that. This is KM analysis for this cohort between these two groups. Yes. So the conclusion is the artery stenosis progression may occur not only in the major intracranial arteries, but also in the extracranial compartment. The extracranial artery stenosis progression may usually present as a reduction in the dot diameter ICA versus CCA, but in several cases, maybe very rare cases, the ECASP may present as an increase in dot diameter ratio caused by the progressive stenosis in the CCA. A reduction or an increase of over 0.075 in diameter ratio ICA versus CCA during follow-up was an independent predictor of the occurrence of the ipsilateral ACNS occurrence. So, this is further consideration for this conclusion. This is another patient. We can see that this is a quasi Moyamoya disease. This is not a nearly normal side. Normal side is obvious the extracranial artery stenosis side. We can see that the wall structure. This is the ultrasound imaging of these cardiac arteries. The wall structure was disrupted, maybe disrupted in the left side. We can see that the intimal and the medial member and the adventimal we can see in the right side. But these three layers of the arterial wall cannot be seen on ultrasound imaging in the left hemisphere. We can see that. This is about these images. Maybe we can see the extracranial cardiac artery stenosis progression. We can explain it with the remodeling, negative remodeling of the ICA disease progression. But why the wall structure of the ICA may have the disrupt? What's the problem of this case? I couldn't understand. This is histopathological studies on Moyamoya disease about in 1997. This is the Chinese cases. We can see that yes, most of the Moyamoya cases the lesions located at the terminal portion and of the IC and the proximal portion of the ACA or MCA. But we can see these two cases. We can see that the lesions involve arteries. Arteries may not just the terminal portion, intracranial portion, and extracranial portion of the ICA. We can the CCA also involved. So I think the extracranial artery stenosis progress in this phenomenon may be not explained by the negative remodeling. Maybe the lesion involved maybe another reasons. So I think maybe we can study like the cardiovascular imaging, the OCT, yes, endovascular imaging maybe a further good method to evaluate this patient.
And we would like to thank the support from NIH and thank you.
Okay, this is our team. Our team is very young. In the workday, we are the surgeons, and in the free time, we are the young pioneers focused on the we are the young pioneers. We are very interested and focused on the Moyamoya disease. So I think the future, I will try my best, try our best for this patient. Thank you.
Thank you very much, Professor Wang, for this great talk and nice presentation. So, any questions from the panel?
Can invite comments from Prof. Dubove as well. Prof. Dubove, any comments from you?
Very interesting lecture. Thank you. I have not questions. Maybe others have questions about very interesting.
So I have how this affects your decision in surgery, if the patient has extracranial stenosis and what your precautions you take in surgery for such patients.
Okay, thank you. Sorry. I think in these characters, I just I think is very used for the pathology understanding of the Moyamoya disease. But if the patient we got the surgical interventions, I think this phenomena is normal because we got the relaxations. The patient is flows need is less in the ICA systems. So we can see the negative remodeling is normal in these patients. I think there was no obvious difference between the in surgical interventions patients.
Right.
But in the conservative patients, it is very useful.
I think if there are no further questions, we can hear the final remarks from Prof. Wasim Aziz.
Thank you, Professor Wang, for this extremely useful presentation. I'm very happy to know more information today about this extracranial stenosis in Moyamoya. Thank you, Raja, and thank you all the ACNS team to prepare such useful
So thank you very much. I would like to thank Prof. Wasim Aziz and Prof. Jiam Wang for this very exciting session about extracranial stenosis in Moyamoya. On behalf of the Education Committee of the ACNS and the President of Yoko Kato, I would like to thank both the speakers of today, Prof. Jian Wang and Professor Atsushi Kanoke, for the time and support for the ACNS webinars. And also special thanks to our chairs, Prof. Aziz and Prof. Dubovoy, and also to Prof. Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, this has been broadcasted on WeChat, YouTube, and Zoom. And as of now, we have around 780 people who have logged in through all different channels. So until we all meet online tomorrow at 7 p.m. Japan time, it is bye bye from all of us. Thank you very much for joining.